Clefts of the lip and palate are a heterogeneous group of disorders affecting the structure of the face and oral cavity. These disorders are divided into three general categories: cleft lip alone, unilateral or bilateral cleft with or without cleft alveolus, unilateral or bilateral cleft lip and palate. Cleft lip and palate is one of the most frequently occurring congenital anomalies. Certain racial groups, including American Indian, Alaskan Native, and Asian, have a higher incidence of cleft lip and palate than do African American or Caucasians. While there is not evidence to support that folic acid decreases the risk of oral clefting, it has been reported that it may lower the risk of oral clefts that have occurred in combination with other malformations or anomalies. Children with cleft lip and palate are at a lower risk of an underlying syndrome than children with cleft palate alone. Therefore, infants with only cleft palate should be examined carefully for other anomalies. The primary goals of treatment and team care for children with cleft lip and/or palate is to achieve optimum growth and function in speech, hearing, dental, and psychosocial development, and to achieve optimal aesthetic repair. Most repairs are done at about 12 weeks of age. However, allowing the infant to reach the rules of 10 before a repair has been associated with decreased risk of post-surgical complications. 10 weeks old, 10 pounds, 10 grams of hemoglobin. Infants with isolated cleft lip generally do not have abnormal hearing. However, infants with cleft palate have significant hearing and middle ear problems. Children with cleft lip only usually do not have significant speech articulation problems. However, children with cleft palate do have speech articulation difficulties. The desired outcome of cleft palate surgery and speech therapy is to have clear articulation by 4 years of age. Up to a fourth of these children will experience something called velopharyngeal insufficiency, or VPI, after their palate repair. Because VPI is a structural problem, it may require surgical management and may not improve with speech therapy alone. These children generally display poorer oral hygiene and have a higher susceptibility to caries. Crossbites are very common after surgical closures of the palate. At age 5 to 7, an orthodontic consultation is recommended. Parents of the infant with these anomalies are the first clients for the long-term psychosocial management of the child. Families who positively accommodate to their children's chronic condition have children who appear to cope at a higher level than those who negatively adapt. All children with craniofacial anomalies should be referred to a pediatric endocrinologist if short stature other than constitutional is identified. Children with a unilateral cleft usually have a deviated septum that causes noisy breathing during upper respiratory infections but does not negatively affect air exchange. The use of special feeding devices enhances bottle feeding for these infants. Introduction of solids by spoon is possible at the same time as unaffected infants. Routine vision, hearing, and dental screening is recommended in this population, as well as some special considerations. The long-term prognosis for children with non-syndromic cleft lip and palate is excellent.